Hi, good evening. My name is Arun Agarwal. I'm a pulmonary and sleep specialist right here in Fishkill, actually, about 3 buildings down. And my main office is in Cornwall. So I'm speaking for St. Luke's Hospital, and they have a sleep lab right in building 400, which is where my office is. So thank you for coming. The way I've arranged the lecture, it's really not a lecture, is this. I decided to do it differently. So here are the topics I intend to cover. What is sleep? Why do we sleep? When do we sleep? How much sleep we need? How do we know we have enough sleep? Effects of too much or too little sleep. Do sleep patterns change with age? A comment about napping. And then how do we approach in figuring out what's wrong with sleep? And then a brief overview of various sleep disorders. Okay. So what is sleep? So sleep is just not that your eyes are closed and you're oblivious to the world. Well, you may be in coma from a stroke, right? That's not sleep. Or you may be under anesthesia. That's not sleep. It's completely different. Sleep is actually a very, very active stage of the brain. Sleep is normal. So normal people's brain either are awake or are asleep. There is no third stage. Coma is an abnormal stage. Anesthesia is an abnormal stage. And in fact, if you see the brain activity by measuring it, sleep is very, very different than coma and very, very different than anesthesia. So sleep is a very active stage. The brain really, if any one of you are musically inclined, it's like musical waves going through the brain, except that you sleep. So it's different. Why do we sleep? Well, it's really unknown why we sleep. There have been elegant experiments to know if you sleep deprived, what happens to the person. Well, the person dies. Of course, those tests have been done in animals. We won't do it in men, humans I meant. But the tests have been done in humans. And the longest person who could survive just before dying, he was rescued, was 37 days. Those tests were done in California a long time ago. And even before 37 days ago, he was losing weight, his immune system was going. He actually got infected because his immune system was low, and he was basically going nuts. Of course, he recovered. And finally, even plants sleep. So sleep seems to be something basic to life. Different life forms have different sleep forms. For example, dolphins, who swim in the seas 24/7, they sleep in half the brain at one time. The other half is active. So sleep can be very, very diffuse across life, but it always happens. So sleep is something essential to life. What it is, we don't know. The prevailing theory in humans, at least, is that during the day, when we're active, because of our thinking, certain toxins accumulate in the brain, and they need time to clear up. So if you ever see the brain is 1 billion cells, each talking to each other through connections. So they're called dendrites. And those connections, if they get blocked, you can't think. And those connections accumulate toxins that need to be cleared. In fact, that's one of the theories for Alzheimer's disease too, that some of the toxins called neurofibrils cannot be cleared, and they accumulate, blocking those connections and thereby inhibiting memory. But coming back to this, that is what it is thought to be, that during sleep, those toxins get cleared from our brain so that we're refreshed, so to speak. When do we sleep? So this, now I'm going deeper into what will lead to abnormal sleep. So this is important to understand. There are essentially 2 different things going on in our brains that influence when we sleep. One is an intrinsic biorhythm that's attuned to the day and night cycle, to the sunlight actually. And in that cycle, we are actually most awake now during the period of 6 p.m. to 8 p.m. Humans are most awake. And then when night falls, there are certain changes that happen, including melatonin. Everybody's heard of melatonin nowadays. Melatonin is one of the leading hormones. So when when sunlight doesn't enter into our eye, the brain signals are transmission to the back of the brain, whether the gland called the pineal gland that secretes some hormone called melatonin, and then melatonin changes a switch in the front of the brain, trying to induce sleep. And then we go to sleep. The average amount of sleep is about 7 hours. The range is 6 to 8 hours. And in fact, people who sleep less than 6 hours have a smaller lifespan, and people who sleep for more than 8 hours have a smaller lifespan. Now, after having said that, there are normal long sleepers and short sleepers, but they're rare. For the most part, for 95% of the human population, the average is 7 hours plus minus 1. So if you do the math, the brain starts waking up at about 5 or 6 a.m. in the morning. That's when the sunlight time is usually, that's when light enters our eyes, shuts off the melatonin. That again switches the sleep-wake cycle. Melatonin is not the only hormone. There are many other hormones, but that is the inciting event, and then we are awake. So as you can see, there's a very, very, very specific biorhythm. What I forgot to tell you is between 2 to 4 p.m. there's a second sleepiness part. So we call it bimodal. Humans are built to be bimodal. Sleep at night and sleep during the daytime. The sleep during the daytime is not as deep or as long. And this part of the sleep cycle is basically responsible for mostly REM sleep. So, and then there's a second cycle, which is just cumulative. The longer you awake, or you stay awake, the more a substance called substance P in the brain accumulates, who wants to tilt the balance towards sleep. So if you sleep for 8 hours, the level is, if you awake for 8 hours, the level is very little. By 12 hours, the level gets enough to put you to sleep. By 24 hours, the pressure is really mounting, and that can overcome the intrinsic biorhythm. And whether you're sleeping or awake, apart from external influences, is basically a balance between these two cycles. So, how much sleep? I think we already went through this. I just went directly to the adults. But newborns sleep 23 hours a day. And folks in their 80s, 90s only sleep 5 to 6 hours. I should have put it there, but for some reason I forgot. So as you can, and this is normal. So as you can see, the amount of sleep is not static either. Newborns sleep 23 hours a day. By infants, all of us have experienced this. We accumulate sleep to 12 to 14 hours, mostly during the night. Children 1 to 5 years sleep 11 to 13 hours. Children 6 to 12, they actually stop napping at about 6, and they sleep 10 to 12 hours. Adolescents sleep 8 to 10 hours, so all our youngsters who want to sleep till 9 o'clock, they're normal. And adults usually means 20 or 21. So here's the basic question. If everything is so variable, how do we know we have enough sleep or not? And actually the answer is based on a very, very simple question. I always ask this when I have a patient with insomnia. When you wake up in the morning, do you feel rested? Are you feeling alert? During the daytime, are you alert enough, except for a little dip during the afternoon? If the answer to that is yes, you do not have a sleep disorder of insomnia. So this is worth repeating. I'll just pause to see if you have any questions related to that. Okay. This is what you were in a way asking. Of course, you were asking related to shift work, but it's essentially true for any sleep disorder. Diabetes is much more common. Hypertension is much more common. Should have mentioned that. Strokes and heart attacks. I mentioned industrial accidents, because the person is sleepy and on the drive back, the risk of accidents is high, and anxiety and depression. These are the more common medical disorders in people with sleep disorders. Another important point I want to stress is that sleep changes over the lifespan. We discussed how, but it's just not the number of hours as I had shown on that slide. Actually, the quality of the sleep also changes. The character of the sleep changes. As we age, sleep occurs earlier in life. So adolescents, they always want to sleep at 1 o'clock, and they're 10 to 12 hour sleepers, and they want to wake up at 11 a.m. But guess what? Their problem is they got to go to school because parents have got to go to work. So we force them out of bed, put them in schools, and that's a problem for them. That's not normal for them. Ideally, their school should start at 11 o'clock and end at 5 p.m. But hey, they live in an adult world. We control the world, not them. So paradoxically, folks who are older, they want to sleep early, normally. I'm just talking normal people. They want to sleep early, and their sleep has actually already been reduced to about 6 or 7 hours. So if you sleep at 8 o'clock, you're going to wake up at 4 a.m. And that's normal. So if somebody comes to me at that age group saying I wake up at 4 a.m., what do? Am I abnormal? I go back to my first question. This one. And if the answer is yes to this question, then I got to figure out how to make this person adapt to waking up at 4 a.m. He's healthy or she's healthy. But how do we adapt to life waking up at 4 a.m.? A comment about napping. I put this slide because I often get asked this. Napping is healthy. About a third of people actually nap in this world. It's just not the Italians and the Indians. Everybody naps. Everybody who has an opportunity naps, let's put it this way. And men nap more than women. Short naps are healthy. And 30 to 45 minutes is the short. And it actually increases the alertness in the evening. Nappers, who are short nappers, are more alert in the evening. Remember when I told you there are two pressures to sleep, and one pressure called substance P is constantly mounting to put you to sleep? That substance P goes away in short naps, adding to increased alertness during the evening. So nappers have two reasons to be alert. One is they're naturally alert during the evening, and two, they remove the substance P by a short nap. So short naps are good. The problem with longer naps is that it will affect nighttime sleep. So if your body is attuned to 6 or 7 hours of sleep and you sleep for 2 hours in the afternoon, now you only have 4 hours of sleep required. And if you sleep for only 4 hours, you're bound to wake up in the middle of the night. So that's why longer naps are discouraged. So now I'm going to switch gears and go to how do we approach sleep disorders. And I like to always think broadly and then narrow down things. So like if somebody comes to me for shortness of breath, I always wonder if it's lung problem or heart problem or anemia or something else. And then I design my questions and examination and testing to narrow it down. Same is true for here. I classify it into three. Insomnia means too little nighttime sleep. Hypersomnia means too much daytime sleep. And the third is sleeping at inappropriate time, either too early or too late, or I should have broken down in various sections throughout the day. So let's talk about all these three groups. The first is insomnia. Insomnia actually is the commonest, by far, the commonest sleep disorder. 60 to 70% of all sleep disorders are insomnia. And actually that has nothing to do with the sleep level. And insomnia, I further divided up into these groups so that one can think of it easily. And the commonest cause of insomnia are secondary to medical disorders. So if somebody has shortness of breath due to COPD or heart failure, they really can't lie down because it interferes with breathing, which interferes with sleep. or if somebody has musculoskeletal issues, it interferes with sleep. And actually, the pain could be anywhere in the body, and that interferes with sleep. The second commonest is actually anxiety and depression. And the funny thing is that people who have insomnia invariably develop depression, and people who have depression invariably develop insomnia. So, so that complicates matters when we're trying to detect what started first. Neurological disorders are very common. Parkinson's and dementia always have a sleep disorder, always. In fact, their brain does not cycle normally, even in the sleep part, and they sleep for half an hour, wake up for 2 hours, sleep for 20 minutes, 1 hour. So their sleep is broken up throughout the day and night, throughout the 24-hour period. Seizures can also affect sleep. The fourth is medications. And actually, I'm going through, in a way, in the order of importance or in the order of frequency. When I analyze somebody with insomnia, I always go through this order, in the order of importance. And you could have multiple disorders. So it's not that if I find CHF, I stop. I still go through all the steps because one could have more than one reason. Medications. There are many medications that actually directly affect sleep. Theophylline is not used much anymore, but that's sort of the poster child, that's why I put it there. But steroids are very commonly used for various disorders and very, very commonly affect sleep. Digoxin used to be used a lot in patients with heart failure and other atrial fibrillation, but for the last 10 years or so, the use is getting less and less and less. I should have put beta blockers too. Beta blockers is almost every patient with the heart has beta blockers on it. I should remember to add beta blockers there, but beta blockers is probably even more common than steroids, quite honest. And then poor environment, this is self-evident, so to speak. I had mentioned excessive napping, which fragments nighttime sleep. And lastly, I come to primary sleep disorders. By primary, I mean there's no other disorder in the body. It's a sleep disorder. And that is the classical sleep apnea, restless legs being the two most, by far the most common ones. I mean, there are others like narcolepsy and cataplexy and the various other kinds of disorders. But over 90% of primary sleep disorders are sleep apnea and restless leg syndrome. So this is how I approach a problem of I can't sleep. Now, I'll come back to treatment in a minute. Equally important, even in a case of insomnia, is sleeping at inappropriate times. So a person who wakes up too early or wakes up too late will also complain of insomnia. They're not going to say I wake up too early or wake up too late. They're going to complain I got a sleep disorder. So I always got to think of circadian, what I call circadian. Circadian means rhythm of the day and night. That's what circadian means, right? So sleep too early. Technically, it's called advanced sleep phase disorder, meaning the entire sleep cycle is shifted from sleeping at 9 p.m. to 6 p.m., let's say. So I gave you an example of which kind of normal person would report that. The elderly. Versus sleep too late, like 1 a.m., delayed sleep phase. A normal person, a normal adolescent would be reporting that. Or sleep at irregular times. You know, they sleep for 4 hours, or 2 hours, 1 hour, wake up for 4 hours in between. Those are the degenerative disorders of the brain, Parkinson's and dementia being the two common ones. Or non-24 sleep disorder. The non-24, because there was a medication that is effective for treatment for the last 2-3 years, the airwaves are blanketed with the non-24, right? So everybody's heard of non-24 now. But what is non-24? So in non-24, what happens is the connection between the eye and the pineal gland secreting melatonin is broken. The most common cause is blindness. So people who are blind, they cannot perceive nighttime and daytime. And the problem is that our brain actually has a sleep cycle that varies from 24.3 hours to 25.3 hours. So in other words, if you put me in a cave, my day is is 24.3 or 25.3 hours long, not 24. Yet we live in a 24-hour world because the sun goes, the earth goes around the sun every 365 days and the moon goes around every 24 hours or whatever it is. So it's the sunlight that keeps my brain attuned to 24 hours. But if I don't have eyesight, if I'm blind, there's nothing to attune me, absolutely nothing. So my brain will now sleep, let's say 25 hours. So I'll be late every 1 hour every day. So if I sleep at 9 o'clock one day, I want to sleep at 10 o'clock the next day, 11 p.m. the next day, midnight the next day, and so on and so forth. And then there will be a cycle when I want to sleep at 6 a.m. So that is called non-24. There are other rare disorders where non-blind people can get it. Those are very, very ill understood. They are degenerative brain disorders. So people with Parkinsons can also have it, for example. But the vast majority will be related to blindness. So, and excessive daytime sleepiness, again, medications is the most likely. Long-acting sleep. There is no short-acting sleeping pill. After having said that, maybe it's not accurate. So most of the sleeping pills we know of are long-acting, 36 to 48 hours. You take a Xanax, it actually is going to make you sleep for 36 to 48 hours. You might feel awake because your higher brain function is making you awake, but you're actually sleeping. The short-acting, the Ambien that you've heard of, or the Lunesta you've heard of, only acts for 2 to 4 hours. So there is no 6 to 8 sleeping, 6 to 8 hours sleeping. It doesn't exist. There was one that existed called Halcyon, maybe about 15 years ago. It went off the market because it was causing some liver failure in some people. So it got pulled from the market worldwide. It's not available. So there is no perfect sleeping pill, unfortunately. Now, some people take 2 Ambiens, 3-4 hours apart to make up the difference. And there is an Ambien that comes 2 pills in one that dissolves at different times in the stomach to make the action longer. It's called Ambien CR. But the point here I'm making is that medication is the most common cause of daytime sleepiness, and Benadryl is another one. Trazodone is another one. Trazodone and Benadryl are often used for people for sleeping. In fact, most of the over-the-counter sleeping pills are all Benadryl. One form of Dramamine, one or another form. So those people often complain of daytime sleepiness. If you don't sleep well at night, well, the brain is going to try and catch up on sleep during the daytime. So, and rarely narcolepsy, and its normal and its other variants, where the brain actually wants to sleep at various times of the day, in addition to nighttime. So what I try to do is group it into various groups, because there are hundreds of causes of a disorder. And in order to fix the problem, you've got to find out the cause, or 2 or 3, before you can actually fix the problem. And that's true for life, right? Any problem in life. So that's why I like to group things in my head, so that a complex problem can be broken into pieces for analysis. So let me now go back to what I skipped. So I went back to the insomnia slide, and this is the treatment for the insomnia. How would one want to treat insomnia? Well, in order for successful treatment, you got to find the underlying cause first, or causes. And in order to do that, you have to go through this exercise. Look for medical disorder, psychiatric, all the 7 groups that I had spoken of. Once you find out what the problem is, well, then it's easy. You do specific interventions. I should have written fix the problem first if it's a fixable problem. If not, we go to sleep-inducing pills. And I think I didn't speak much about it, but there are those that induce sleep faster. So those are the melatonin-like drugs. Melatonin being the calmness, it's not a drug, it's freely available over the counter. 5 milligrams is the proper dose. And nobody makes money from it, right? It's cheap. So the drug companies came up with Roserum, which is quite a few $100s. Same thing. It works the same way. So, and those that maintain sleep. So we talked about Ambien, which works for 2 to 4 hours, or Ambien CR, which would prolong its effect. There's no 5 to 6 hour drug, and then Valium and Lunesta are longer acting drugs. They all work in the same, so these two drugs work very differently. This is like a melatonin thing. It shifts the balance between sleep and wake and induces sleep. And this one, these benzos as they're called, maintain sleep, acting in a very different area of the brain. However, the preferred approach to treatment of insomnia, besides fixing the problem that caused it, is cognitive behavior therapy. It's a form of psychotherapy. It is highly, highly, highly effective, and in fact, it improves the same hormones in the brain in the same areas that these drugs do naturally. And it has no daytime sleepiness because it's not hanging around during the daytime. So cognitive behavior therapy is clearly the preferred approach to insomnia. In the past, one had to go to a psychotherapist for it, but no longer. CBT is now freely available over the internet through internet-based programs. And in some states where there is no easy access to doctors, it's actually even approved by the FDA. So it's not approved in New York, or it's approved in Nebraska. However, the FDA can do whatever they want. People are freely using CBT techniques. This was the circadian disorders, meaning sleeping at different times rather than day and night. And I did not put a slide for treatment, but treatment is basically based on melatonin to induce sleep or delay sleep, and light exposure. So in people with advanced sleep phase disorder who wants to sleep at 6 o'clock, you expose them to bright light. This is not bright light. There's maybe about 10 times more than this, and the sleep will be delayed. And conversely, people who sleep too late, if you expose them to bright light in the mornings, the sleep cycle will be pushed. Just like naturally, remember I said my sleep cycle is 25 hours, but because the day and night cycle, it gets pushed to 24 hours. It's the same technique, except you're using artificial light. For non-24, it's far more difficult to treat it with light because they don't have perception of light, or the connection to their pineal gland is broken, so you cannot use light. There are other ways to deal with it, but the drug that is, I forget the name right now, actually works quite well. I also wanted to tell you something about jet lag, what came into my head, because I didn't make a slide for jet lag. Yes, so let's take the flight to London again. If you notice, has anybody flown to London? No. Okay, so what happens is you board the flight at JFK at 9, and you're not even out of Long Island, which hardly takes an hour and a half, and you fed dinner, right? And then you kind of put to bed, and they douse the lights and all. And 4 hours later, they wake you up with breakfast, right? So there is a method to their madness, because going back to my 24-hour brain, adapting to 24-hour Earth and Moon and Sun because of daylight, that's the most powerful way to adapt. The second is food timings. Our brain responds to timing of food, breakfast, lunch, and dinner. And you are asked to adapt. The fastest way to overcome jet lag is to live the life of the place you landed. So this example of my flight is landing just about at breakfast time in London. So they give you breakfast. Not because they feel you're hungry or something, but because they're trying to adapt you. They're trying to reduce your jet lag. And our natural tendency, if you're on vacation, is catch up on sleep. That's the last thing you want to do. You somehow have to trudge along, keep your normal breakfast, lunch, dinner times, and just overcome the physical tiredness of the day. Or you start 5 days earlier in New York and adapt to it.
It's interesting.
Or you can, of course, mix them both too. So about sleep apnea. Now, amongst the sleep disorders, remember insomnia is by far the commonest. Circadian rhythms are by far the least important. Sleep apnea is maybe about the second commonest. And that is the commonest reason people have to go to the sleep lab for studies. About 18 to 20% of the adult population have sleep apnea. That's a huge number. That doesn't mean they need treatment, but they have sleep apnea. Mild sleep apnea does not require treatment unless the spouse wants it. Snoring is less common for comparable sleep apnea, snoring is less common in adults. And I always think of sleep apnea in 3 different age groups as completely different illnesses. In the children, it causes growth retardation. It needs to be detected, and it can be fixed completely by tonsil and adenoid removal. That does not work in adults. So there's something different in the kids. In the elderly, they may have significant sleep apnea, yet they may be not snoring at all. They are actually the most at risk for stroke, increased risk of stroke and heart attacks and atrial fibrillation. And then there's the middle. The commonest people I see, however, are in their 30s, 40s, usually men, usually bulky men, usually short necks and chubby and muscular men. Those are the folks that are not in trouble. They usually come mostly because their spouses are sending them, but many of them are also sleepy during the daytime, so related to accidents or near accidents. But they're otherwise healthy, apart from hypertension. And they are the ones who, in their 60s, have a significantly higher risk of strokes and heart attacks. So these 3 groups work differently, but they all, apart from the children, all suffer cardiovascular events. Also for people who have heart failure, the heart failure doesn't get controlled that easily if you don't treat sleep apnea. Same is true for atrial fibrillation, diabetes, strokes, heart attacks, I spoke about it. And it's treated with positive airway pressure, that's PAP. And there are various modes for it. Now there's another mode called automatic PAP. I should have added that too. But in this problem, in this illness, what's really happening is that the back of the nose, also let me give you another example. Our breathing tube really starts in the nose, goes in the back, and down our throat. From the Adam's apple downwards, it's a rigid tube because there's cartilage holding it tight. It's like a corrugated water hose, garden hose. But from here to here, it's just like an uncorrugated rubber hose, garden hose. Completely collapsed. And when we breathe in, see what happened to my nose? It went in. The entire tube here becomes narrow when we breathe in. That's normal. It's the degree of narrowing that makes the difference. As it narrows to a chink, you start snoring. And when it stops completely, you stop breathing because air can't pass through anymore. That's when the oxygen level goes down. The brain senses low oxygen and therefore has to lighten its stage of sleep. From deep sleep, it has to come back to shallow sleep or even awaken to send some signals to these muscles to tighten up and open up. And at that time, because it happens suddenly, the blood pressure shoots up. And then when the blood pressure shoots up, it damages the blood vessels. And over time, 20 years, 30 years, the blood vessels of the heart and the brain give way, causing strokes and heart attacks. And during the daytime, because this person did not sleep enough in deep sleep, the person is sleep deprived, and that leads to the effects of sleep deprivation, accidents and other things. So that whole thing is called sleep apnea. And the reason for treatment of sleep apnea is not only snoring disturbing the spouse, but also daytime sleepiness with loss of enjoyment and accidents, but also the long-term risk for strokes and heart attacks. And we don't have a cure for it. We only have a fix for it. And here's a collapsing tube. So what do you do in the garden if the tube is kinked? You turn the water pressure on, and the tube opens up, right? Same thing we do here. We breathe pressurized air. That's what CPAP is. So CPAP is a machine that sucks in room air, adds pressure, throws it out the other end. The other end is attached by a hose to our face, and that pressure is then transmitted during breathing to our passages here, literally just forcing it open. So that's what CPAP is. C stands for continuous pressure, where we set one pressure coming in and going out. BiPAP is we set it differently, and APAP is a newer machine where the machine has a computer chip and it can decide for itself what pressure is needed. They're all equally effective. One is no better than the other. So, restless leg syndrome, I think we should talk about, and I believe that's my last slide. Yes. Restless leg syndrome is not uncommon. It is very, very common in pregnant women. I'm sure some of you must have experienced it. And the reason is that pregnant women do get iron deficient. And iron is needed to produce a hormone in the brain that's based on dopamine. And in a particular area of the brain, when it lacks dopamine, causes by an unknown mechanism a feeling of what is called restless leg syndrome. So what is restless leg syndrome? In this, the person complains that in the evening, and usually it's only in the evenings, and it's unknown why it's in the evenings. And the second thing is at rest. So in the evenings, if you're walking around doing your work, nothing happens. But when you sit down or lie down in bed, then you start getting this feeling that I'll shortly describe. Or I'll just describe it now. It's a peculiar feeling that something may be crawling on the legs, or some sensation that is unpleasant. And the fourth characteristic is if you move your legs like this, you get relief. So in the evenings, at rest, an unpleasant crawling sensation, usually in the legs, that is relieved by leg movement. So those are the four criteria we look for to diagnose somebody with restless leg syndrome. Now, yes?
I have that restless leg syndrome.
Yes, it's actually very common.
And I usually use cold water. Just
Right.
use cold water on my legs and on my arms.
Now, restless leg syndrome is actually only a handful are associated with iron deficiency. I always look for it because in the elderly, there's a higher chance of colon cancer, and I've actually detected colon cancer in people who just present as restless legs. I do the iron, and the iron is low, and lo and behold, a colonoscopy shows an early colon cancer. But that's not common. The most common, the iron levels are normal. So in those cases, it is unknown why it is happening, but giving them dopamine drugs to fix the deficiency of hormone in the brain is highly effective. A common medication that is used for depression also causes restless legs. Lexapro, Paxil, all the entire group of what are called SSRI is a very, very common cause of restless legs, and one can stop those drugs and the restless legs goes away. So those would be the 3-4 common causes of restless legs. It's very easy to treat, usually. One word of caution. These dopamine drugs are also used in Parkinson's disease, except that they're used at a much higher dose. So common worry is, does restless leg progress to Parkinson's disease? Parkinson's disease is not a good illness. It's actually quite a bad illness, and it will always progress. But there is no connection between restless legs and Parkinson's disease. Now one can have two diseases together, but and in some cases of Parkinson's disease, they may be presenting in the beginning with restless legs, but most cases of restless legs have nothing to do with Parkinson's disease. So I always make that point. So that I'll stop here. These are some additional websites that you may want to note down. These are not commercial websites. I stay away from them. These are the first one, sleepfoundation.org, is actually the website for the National Sleep Foundation. It does a lot of research. It's funded by the NIH. This is the American Academy of Sleep Medicine. It's the organized academy for sleep doctors, and this is their website with equally good information. And these two organizations freely exchange information. RLS is specifically focused towards restless legs. There is a foundation, a not-for-profit foundation called RLS Foundation that runs it. Now, sleepapnea.org actually is run by a technician who got interested in this and actually has formed a beautiful website. It is devoid of commercial activity completely. And it comes up with great things, but most of the same things you will also find here. These are more scientific. These are two are more practical.